for the potential treatment of the plantar fasciitis, it's not going to be a main focus of the class, but just so you would know some of the common practice that people would often use. Some people would like to stretch the calf, so you can relieve the tension coming from the calf muscle or Achilles tendon. Some people would like to perform some stretch over the plantar fascia itself. Try to again relieve some of the tension that you're placing on the bottom of the calcaneus. You can actually put some water on the bottle and put them in the freezer, so you have a frozen bottle. You can put that frozen bottle on the floor, and you can have yourself sitting on a chair. Try to roll that frozen bottle right on your feet. Try to get some massaging and the ice effect at the same time. Some people would like to just maybe do some kind of tennis ball rolling over the plantar fascia. If you happen to have pes planus and that's what was putting you making you more prone to sustain this kind of injury, then maybe you can get a lot of benefit from obtaining the proper custom orthotics for yourself to maybe lift up a little bit of an arch. This is known as night splint. Not anybody's favorite, but remember we talked about how when you're sleeping, your foot is going to go into the plantar flex position, and that is going to cause a lot of pain in the morning, right? So we can recommend the patient wearing something like this when they go to sleep. They are going to go sleep with it. It's night splint. So that way they can keep their ankle in a kind of dorsiflex or more of a neutral position throughout the night. So the first step in the morning is not going to be as painful. That's the idea. I had a couple different patients try that night splints in the past, and then nobody liked it at all. They said it was very uncomfortable and then very hard for them to sleep. But if it happened to work for your patient, it might be worth just trying. And if they happen to like it, they can certainly wear something like that. Next injury is the sesamoiditis or sesamoid fracture. We did talk about, you having a little two small bones on the bottom of the first metatarsal, first MTP joint. You can potentially have inflammation over those bones, maybe from an acute fall like this, or maybe chronic repetitive pounding on those bones, or you can actually sustain the fracture with a very similar mechanism. What you're going to find is a very, very well localized pain right on that spot when you are to palpate it. Okay, and if they are to say perform the heel raise, which is going to put more weight right on the sesamoid, or if you ask them to walk on the toes, I would typically going to increase the pain that they're experiencing. So if that's what you're suspecting, you can ask them to do all these things to see how they're going to do. Some other possible findings that you might be able to find, see in a patient, maybe again another episode of recent weight gain, and maybe pes cavus or plantar. If it's a fracture, something like this, that would indicate a fracture. They might complain or report some kind of sensation of snapping or cracking at the time of the injury. And again, if you happen to have a fracture there, then typically the pain level is going to be much higher than just the inflammation. So if you're to palpate in the spot and then they complain significant tenderness there, you might want to suspect a fracture, and then might want to refer the patient to maybe to a physician to potentially get an x-ray to rule out the fracture. Next condition is known as tarsal tunnel syndrome, but before we get into the condition, let me explain what the tarsal tunnel is. This right there, this arrow, that is your tarsal tunnel. As you can see, you have this distal end of the tibia and fibula, calcaneus, and talus. What you see is you have this fibers kind of running, connecting medial malleolus to calcaneus. These fibers are known as flexor retinaculum. We're going to talk about this condition once we get to the ankle chapter a little bit more. But underneath of that retinaculum, you see this very narrow space. It looks like a tunnel. Okay, so this is a tunnel created by your tarsal bones. That's why it's known as tarsal tunnel. In this tunnel, it's such a small tunnel, but you have a lot of structures running through the tunnel. What you have is the 3 specific tendons, as well as 1 artery and 1 nerve. So again, here's your tarsal tunnel. Okay, here's a retinaculum and a lot of tendons running together, and a nerve and an artery. The structure that you have in this tarsal tunnel, you can actually remember that as Tom, Dick, and Harry. Tom, the T is for tibialis posterior muscle, actually the tendon part of that muscle running this way, so that is very close, running very closely right posterior to the medial malleolus. The next structure you find, Tom, Dick, the D stands for, or that is for flexor digitorum longus. So this is a tendon that's running right next to Tom, okay, running all the way, wraps around, and then go down. Flexor digitorum longus. Tom, Dick, and this A is for posterior tibial artery. We already talked about this artery. This is one of the spots that you can palpate, the pulse, right? Right next to that, this is red, right next to the red, you can find the yellow. Yellow is for the nerve. So posterior tibial nerve running right next to the artery. The last one, the hairy, is for flexor hallucis longus. Tendon right there. Okay? So you can remember these structures in this particular order by you saying Tom, Dick, and Harry. Okay? So this tunnel, again, the floor of the tunnel, the bottom part of the tunnel is made up with a calcaneus and talus and tibia, and it's closed. The roof of the tunnel is the flexor retinaculum. You might need to know the roof and the floor of the tunnel and what's inside. So because you have such a small space for many structures, it is very possible. I mean, imagine this: if you happen to have some kind of tendinitis, okay, within one of those tendons in there, when you start to experience some inflammation and swelling start to accumulate, it can easily start to put some pressure on the structures that you have within the tarsal tunnel. The most problematic one is the compression force placed over the posterior tibial nerve. When you put the pressure or compression over the nerve, you start to experience sometimes burning sensation or radiating pain, shooting pain, sometimes numbness, tingling, stuff like that. Anything along the line is a possibility. So, onset of the tarsal tunnel syndrome, if it's happening because of an acute injury and swelling start to accumulate, then it could be acute, or it could also occur as a gradual thing. You would expect to maybe find a diffused pain. This kind of a condition, it's very difficult. It's really rare for you to find a localized pain. The pain would start to diffuse because it's the nerve that's being affected. Burning sensation, numbness, paresthesia, again, kind of tingling sensation along with the plantar surface or medial surface of the foot. If you are to perform, whether that's active or passive, dorsiflexion and eversion, I mean, imagine you doing this with this picture. If you're to dorsiflex and then evert, you're going to put more stress, okay, over the tarsal tunnel, so that would make the condition worse. So you can confirm that, okay, by performing a dorsiflexion and eversion. Some other possible findings, they might start to develop some interesting signs and symptoms like cold intolerance. So maybe if you are to say ask them to ice their foot or something like that, they may not be able to take that kind of a stimulation. Maybe they become super sensitive to cold. You can perform one special test known as Tinel sign, which I'll have that in the very next slide. Some management that you can do, maybe rice. Take some NSAIDs to calm down the inflammation if that's what's causing it. Orthotics to help out, maybe take some stress off the tendon. Put them in a walking boot so they don't have to do too much of a dorsiflexion or eversion, which might make the condition worse. Worst case scenario, what they could have is to have a surgery. What they ultimately do with the surgery is they're going to, let me go back a slide, cut this flexor retinaculum and then release that roof, so you don't really have the roof anymore. The tunnel is now wide open, so you wouldn't experience any compressive force across the tunnel. Tinel sign is very simple. What you can do is you can either use your own finger or you can use a reflex hammer. What you're going to do is you're going to visually locate the tarsal tunnel, and whether you're using a finger or reflex hammer, you're going to tap the area gently several times. You don't have to tap it like 20 times. I would say at least 3 or 4 times, okay, to see if the tapping is going to cause any reproduction of the signs and symptoms. Okay, if they do complain, numbness, tingling, or burning sensation, radiating, anything along with that line, you call that as a positive test. Unfortunately, this is a very famous test, but not too many people really studied this test. So what we know really is the sensitivity being very low. It's very close to like you rolling the dice. Even the quadus of this study is not that awesome. So we don't even know if this test is useful or not at all. Fracture. You can sustain a fracture with a metatarsal. And the classic one that I want you to know is a fracture that could occur in the base of the 5th metatarsal. I want you to pay some close attention to this particular picture right over here. Depending on what part of the base of the fifth is being affected, we have 3 different names. Okay, if it's affecting the very tip of the base of the fifth, we call that as a Valgen fracture. If it's affecting the kind of a mid portion, like 1 centimeter distal from the base, we call that as a Jones fracture, and a little bit closer to that, the red area is a stress fracture. So depending on the area, we have 3 different names. You would typically expect a patient to sustain something like this with a severe inversion force. Okay, so it's very possible that they might come to you and say, I think I just twisted my ankle, and you ask them, okay, where's your pain? And they don't really point the ATF, and then they go straight to the base of the fifth. It's typically a bad news. It could indicate any fracture, okay, from these 3 potential types. Pain characteristics: the pain is typically very well localized. Swelling would often appear very rapidly, and you might be able to even palpate the crepitus over the area. If you just suspect a fracture on the bone, then there are pretty good set of the special tests that you can perform really on anyone. So here, now if you're to sustain a fracture here, a Valgen fracture, which is going to happen at the very tip, like you can see in this picture, this is going to happen because one muscle known as peroneus brevis is going to wrap around and actually insert right on the base of the fifth. So this Valgen fracture is actually coming from the tensile force, okay, stress placed upon a tendon, which was transmitted to the base of the fifth. Okay, so that force was strong enough to actually pull the little piece of the bone away, chip it away. This Valgen fracture, though, is not as bad as Jones fracture. Yes, they're gonna have to be in a walk-in boot for a few weeks, maybe 3-4 weeks or so, but it typically is going to heal pretty well. That's the good news. Now, when it comes to Jones fracture, which is a little bit more distal compared to the Valgen fracture, unfortunately, this is not a great type of fracture. It's associated with a very high non-union rate, meaning that you can just try to let it heal for a very long time, but it may not heal at all, depending on the patient, depending on patient's age, and then all that good stuff. But the reason why is that that area right there is a very avascular structure. Okay, so you don't have too much of a blood supply to the area. It's just very difficult for your body to heal. So you can try to walk in boot for a very long time, but the chances it may not heal at all. If the patient is young enough, the doctor might say, okay, we're just going to wait for a little bit to see if it's going to heal. If the patient is older or the patient is pretty young, but maybe sustained this fracture for the second time, the option is typically the surgery. They're going to use the nice kind of a big pin, okay, to try to connect those bones together. Recent evidence actually going to suggest that if you have to use the bone graft with it, it's probably going to heal the best. The last one is a stress fracture. You can sustain a stress fracture in any of the metatarsals, but again, it could be the fifth, it could be the second, third. This X-ray will actually indicate the stress fracture to the third. Stress fracture affecting the metatarsals. Any metatarsal is known as march fracture because we used to see a lot of that from the marching within the military setting. But if I can point out one specific metatarsal that's most commonly affected by this condition, it's going to be the second metatarsal that's right next to the first. Okay, especially if you happen to have specific alignment issue like Morton's foot, then you're more likely to sustain this condition. Stress fracture is a little bit more difficult to detect compared to a regular acute fracture. Pain is typically dull. It's very difficult to pinpoint. They might complain some night pain. So I would ask a question like, okay, when you go to sleep at night, does it wake you up in the middle of the night, or does it ever start to ache when you're just laying down in the bed? If it's more of a different muscular information, soft tissue injury, they probably say no. But if they are to complain, yeah, I actually happen to have this pain that would wake me up in the middle of the night, that could indicate a such fracture. Pain will typically increase with the activity. Look for some deformity issue. Again, Morton's foot or maybe pes plantis or hagus valgus might be an issue. They can't use the big toe well and then start to put a little bit more pressure in other toes. Recent weight gain is a possibility. Maybe they start to run more or practice longer. And again, these special tests are going to be useful for you to know, but X-ray may or may not be positive.